Welcome to the Motivational Midwife. My name is Lynn Jones, and today we're going to look at drug administration. So let's look at drug administration. This won't go into the specifics of each type of method of administration. It's more of an overview. So thinking about our legal framework, obviously everything we do needs to sit within the NMC Code of Conduct, our professional conduct, and there is a section within that about medicines management. The human medicines regulations actually is the main sort of government legislation that covers administration of medications, and there is a section within there that specifically applies to midwifery. The government website have a small section on it as well about sale and supply and administration of medicines specifically for healthcare professionals. And then the RCN, the Royal College of Nursing, also have quite a useful guidance around administration of medications, particularly in healthcare settings. So there's different types of drugs that the sort of umbrella around the types of drugs. So there's the general sales list. This is essentially anything you can buy over the counter. So things like paracetamol and cough medicines, all of the things you can kind of buy over the counter. Pharmacy-only medicines, these are medicines that can still be bought by the public, but they are behind the counter, so you can't just wander in and pick them up. You do need to actually speak to somebody within that pharmacy department, and they very often will ask other questions about medications that you're on, so they know that whatever you're trying to buy doesn't interact with what you're on already. Some of the pharmacy-only medications that I can think of off the top is like your emergency contraception. That's a pharmacy-only prescription. There's one that I use myself for migraine called Bucostem, which is essentially buccal Stemetal, so it's an antiemetic. And years ago, it used to only be on a prescription, but now it is one of the pharmacy drugs that can be bought behind the counter. Then you have your prescription-only medicines. So these are ones that are prescribed by either doctors or nurse prescribers, but they are on a prescription and they can only be dispensed by a pharmacist or a setting that is particularly licensed for that use. Then we have controlled drugs. So these are things like your opiates, so your pethidine, your diamorphine. They are controlled drugs, and there's a very strict set of rules around controlled drugs, particularly around sort of the ordering, the storage, and the safe disposal of controlled drugs. And the one thing that springs to mind, certainly from many years ago when I was community midwife, was that we used to carry pethidine for home births. It's not something we do anymore. Or generally it's not done. Normally if somebody's having a home birth and they're keen to use pethidine, then it is the woman's responsibility to go and get a prescription from her GP. That pethidine is then her property. You cannot take it away and dispose of it for her. She needs to take it. If she doesn't use it, she needs to take it to a pharmacist and they will safely dispose of it. So there are very strict guidelines around controlled drugs, and controlled drugs as students, you cannot, although you might be able to be involved in as a third person in the check-in, you cannot administer controlled drugs as a student. Then we have patient group directives. So these are generally for things, I'm just trying to think of one off the top of my head. often it's things like anti-D and Oromorph, where you've got a large population or vaccinations. Yeah, they're quite they're often on a PGD, because you've got a large group of people that are going to be having the same drug, the same dose of that drug. But with a patient group directive, you as an individual have to be trained around that specific drug, because each drug on the PGD is for that drug only, and it's for, so if I've done the training for, we used to have, we have Oromorph, I think, on the PGD. So it's me that can administer the Oromorph. I cannot allow my student to administer it because she hasn't had the training. However, if I get a doctor to prescribe it, the student can do it under my direct supervision. However, to say that the patient group directive is for you, that individual person. It is you that's had the training, not it's not a blanket one that anyone can use. It has to be the individual person that's using it. And then we have the midwives exemptions, and these can be found in the appendix in Working as a Midwife in the UK on the NMC website. There's quite a nice appendix there, and there's quite a large number of drugs that we can administer. And be careful here, because we are not prescribing, we are not nurse or midwife prescribers unless you've done a separate course, but we are administering drugs under the midwives exemptions. And there's quite a strict framework in which we can give certain drugs. So, for example, we can administer pethidine, but only to women in labour. So we can't just randomly decide that somebody, say, in very early labour or for an analgesic post-section, we couldn't just give it under those circumstances. So there is quite strict rules and guidelines as to the circumstances in which you can administer the midwives exemptions. So it's worth having a look at those and seeing which ones we can administer and which ones you can't, particularly as a student midwife. It's a little grey at the moment, I think, with the NMC and some of the intravenous stuff. So looking at the different routes of administration, so you've got oral, which is obviously by the mouth. You then have, and to be fair, most medications are, for most of our women in our care, will be oral. So things like paracetamol, antibiotics. Then we've got injections. So you've got your intramuscular injections. So things like anti-D. You've got your intravenous. So you might have IV antibiotics or fluids, because they count as drugs. So even Hartmann's or saline do count as drugs. And there you've got subcutaneous, so things like your deltaparin, Clexane, and intradermal, so that would be things like your BCG vaccinations. Then medications per vaginum, you're thinking of things like maybe Canesten for thrush. Per rectum is into the rectum, and that's often some medications can be given per rectum because particularly for people who are unable to tolerate some oral, it is absorbed quite quickly. But the most common one we use probably is diclofenac after suturing. Topical, so you're thinking about any sort of, it may be a steroid cream, an emollient, they're actually put directly on the skin. Inhalation, so it's breathed in, that would be things like Entinox. And then you've got intrathecal and epidural. So your intrathecal medications, they're delivered directly to the cerebral spinal fluid and superficial spinal cord. whereas epidural drugs diffuse through the dura into the cerebrospinal fluid, so they take longer to actually work. So you may have heard the terms enteral and parenteral. So enteral, it just means that these medications enter the bloodstream via the gastrointestinal tract. So that would be anything sort of oral, buccal, buccal. It's where it's actually just popped in next to the gum, sublingual under the tongue, or rectal. They're all enteral routes of administration. So they go via the gastrointestinal tract to the bloodstream. Whereas our parenteral routes, these are your injections and the epidural. So looking at how drugs actually work. Okay, so the first part is they're absorbed. So oral ones go, as we said, through the GI tract to the liver, and metabolism begins there. All the others pretty much directly enter the bloodstream. We need to think about timing because of drugs, particularly with what you're aiming to do is keep an optimum plasma level, blood plasma level of a drug. So the most easy one to think about is antibiotics. And if you keep your times very consistent, so if, for example, a drug has been prescribed 3 times a day, ideally you want to have your spacing 8 hours apart so that you keep the plasma level of that drug at a constant, and then it will work more efficiently. Things that will definitely have an impact on absorption will be gut motility. So remember that in pregnancy, our gut motility and that all slows down. So things might take longer to, transit time is going to actually be longer, whether somebody's eaten or not, because that can also affect. So it's important that actually medications are taken as they're directed, either before food or after food, because that will be specific to how that drug is absorbed. Acids and enzymes in the stomach and lipid solubility. They'll all have an effect on the absorption of drugs. Then looking at our distribution, okay, that's distributed via the circulatory system. Generally, drugs bind to plasma proteins, and things that will affect that really are drugs that distribute into body fluid will be affected by fluid balance. So if you've got somebody that's very dehydrated or very edematous, that's going to have an impact on drug distribution. And those that distribute into fatty tissues, that's going to be influenced by the amount of fat. So if you've got somebody that's very thin, very low BMI or malnourished, or equally the opposite end of the scale, someone who is quite obese, that is going to impact on that. And the dosages of the drugs may need to be adjusted accordingly to actually get that optimum level in the blood. And obviously pregnancy, the blood chemistry changes in pregnancy as well, and that can also have an impact. So thinking of metabolism, okay, that usually happens in the liver, and things that will impact on that, of course, will be age, and if people have already got pre-existing liver impairment, there's genetic factors will also have an impact on it. Any sort of diseases, particularly cardiac or respiratory disease, that have an effect on the blood flow and oxygen flow to the liver is obviously going to impact. Certain drugs that interact with each other, and what happens in the liver is they're metabolized by the liver enzymes to become water soluble, and then that's going to help with excretion. So looking at the last sort of segment in the pharmacokinetics, so how drugs actually work. The kidneys do most of the elimination, okay? And when we're thinking about half-lives of drugs, that is the time taken for the concentration in the plasma, so how much is in the blood plasma, to reduce by half, so 50%, okay? So if pethidine, for example, has a half-life of 6 hours, I believe, so it's going to take 6 hours for the blood plasma concentration to have reduced by 50%. So if we're thinking about potentially side effects for the baby, you have to be watching that baby, because potentially it will take that 6 hours for that to drop. Obviously another spelling mistake there. Pregnancy obviously will have an impact on it as well, because we've got increased blood flow to the kidneys and liver activity, so there is increased drug clearance and elimination, so that the body is trying to get rid of things much quicker. So it's important that any women who are already on pre-existing medication, so people perhaps with epilepsy that are on anti-epileptic drugs, really do need to review very quickly into the pregnancy, because of these changes that pregnancy have. It could be that their meds are being excreted much more quickly, and so either their dosage or their medications completely may need to be changed. So then thinking about our rights of medication management, okay, so you will see in some places there's 5, sometimes there's 10 rights, commonly there's 7 rights of medicines. So first of all, we need to make sure we've got the right medication. So is this drug due now for this patient? Is this the medication that they're supposed to be on, that they're not allergic to it? Is it the right patient? So and I use the term patient because obviously the rights of medicine management cover nurses as well as us midwives. So have we got the right patient? So how are you going to know that? 2 ways. A, you need to ask them. So you need to check their details with both their name band that they should have on and the drug chart that you are using. And it's not appropriate to say, for example, oh, you know, are you Lynn Jones? Because if you have somebody, particularly who English is not their first language, they may not really understand what you're asking them and just say yes. So it is much safer to say, can you tell me your name? Can you tell me your date of birth? Are you allergic to anything? And then check your hospital number against the wristband and the drug chart as well. So all of those details must match. If they don't match, you must not give that medication. So have we got the right dosage? So again, this comes back to looking at knowing your how drugs work. So if I have somebody with a very small BMI and she's been prescribed a particularly large dose, say, of pethidine, I might question that and say, actually, you know, that may be too much for her. She may need a much smaller dose, just for argument's sake. Only because I have seen pethidine 100 milligrams given to quite a tiny person, and it totally knocked her out completely. So, you know, do think about that. So have we got the right dose? Is it you know, this is where you have to have an understanding of the drugs you're giving as well. You know, is that the normal dose for that drug? If somebody's written up, for example, I'm trying to think of one now, 2 grams of something, when you know that the normal dose is 1 gram, you should question it. You know, people make mistakes, doctors make mistakes. You are your patient's, your woman's advocate, so you are there to protect her and advocate for her. So if you're not sure of something, then you need to check it. If you're not sure what the correct dose is, then there are places you can go to. There's the BNF, so the British National Formulary. There's an online thing called Medusa. You can use that. That there are a number of sources that you can access. Quick and easiest one, I always think, is ring your hospital pharmacist, because they are totally knowledgeable in all matters drug related, and they can advise you probably better than anyone, I would say. So I use them a lot if I'm not sure about something. Is the drug, has it been prescribed for the correct route? So is that drug that's been prescribed, would you be expecting normally to be giving it orally or intravenously or intramuscularly? So, for example, one of the emergency drugs we use is something called carboprost, and it's 250 micrograms, but it can only be given IM. If you give it IV, you will kill her. So, you know, it is extremely important that you know the correct route of administration for these drugs. Is the drug due? Is the right time? So is this drug due, or you know, is there some reason it's being given at a different time, and has that been documented appropriately? Is it being given for the right reason as well? So, you know, are we, if she wants analgesia, is she in pain, or are we just giving it because it's prescribed? Have we actually asked her, does she want pain relief? Because very often, particularly for post-caesarean section ladies, they are written up for regular analgesia, so paracetamol, whatever, and we merrily give it out 4 hourly or 4 to 6 hourly. But actually, she may not actually want analgesia at that point, and they do have a right to decline. So, you know, is it being given for the right reason? And then, most importantly as well, document. Okay, your documentation needs to be correct. So not only sign your drug chart, but also write in the notes that the medication has been given. And if it's an analgesic, then go back and make sure that there has been, she is feeling more comfortable after that analgesia. Don't just give it and wander off and don't go back to her. So you should really go back and check that she is more comfortable now. If you, as a student midwife, you can administer medications under the direct supervision of your midwife you're working with, but not controlled drugs. But I would say take every opportunity to be involved in the checking and preparing of things like IV antibiotics, controlled drugs, you know, anything, syntocinon infusions, you know, make yourself involved as much as you possibly can as a third person to get that experience in checking and making up medicines correctly. And there you have it, drug administration. I hope you found that useful. If you haven't subscribed to the channel, please do so, and also look out for us on Facebook at The Motivational Midwife. I look forward to seeing you next time.